I'm Ethan, this is Kevin, and we're doing a case study titled 38-Year-Old Woman with Fever, Headache, and Confusion. So a little bit about the patient history. As previously said, she's 38 years old. 2 weeks before admission, she took a vacation to St. Louis, where she hiked in the woods and went to the zoo. 6 days before admission, she began a vacation on the Atlantic coast of Boston, where she was bitten by mosquitoes. She ended up returning home after 2 days because of the onset of symptoms. So 4 days earlier, as said, she began to have a headache that gradually increased, accompanied with phototopia and mild neck stiffness. 2 days before admission, she believed that she had a mild fever. A day prior, she was admitted to a different hospital where she was told she had a viral illness and was given fluids and discharged. But on the morning of admission, she woke up with shaking chills and a temperature of 40 degrees Celsius. During the day, she was aware of a rapid heartbeat, lightheadedness, and lethargy, and her husband observed how she was confused and decided to bring her to a different hospital to be evaluated. She had a history of Hodgkin's disease at 22, which was treated, and had a healthy history after that. No history of smoking, drinking, or taking any drugs, did daily exercise, and had no history of being in contact with any animals or sick people. So day 1 and 2, her temperature decreased to 36.4 degrees Celsius through numerous tests. It was determined that her lungs, heart, abdomen, arms, and legs were all normal. She was alert and oriented, but could only speak in phrases of 2 to 4 words rather than complete sentences. Staining of cerebrospinal fluid disclosed abundant leukocytes, also known as leukocytis, which can be caused by various factors such as inflammation, infection, and autoimmune disorders. These are all things that the doctors were thinking about due to her symptoms. And during day 2, her temperature rose back up to 39.8 degrees Celsius, accompanied with rigors and drowsiness. When questioned, she knew the month, but not the date or the year of the ages of her children, and could only respond to questions with yes. MRI scans show that there was a subtle increases in brightness on T2 images in both hippocampal regions, signifying the chance of an array of different causes from inflammation to demyelination, or even the presence of a tumor or other lesions, and possible slight meningeal enhancements signifying abnormal increase in the signal intensity of the meninges, which is a characteristic of infections, inflammation, tumors, or bleeding in the meninges. Day 3, her temperature stayed around 39.2 degrees Celsius. She was responsive to commands more than she was the previous day, although she could not distinguish the right hand from the left. During the day, she reported improvement in her headache and was able to recognize her location. EEG revealed generalized low amplitude slowing and continuous focal slowing over the entire left hemisphere. Low amplitude slowing means that the overall electrical activity of the brain was reduced and the waves were slower than normal. And focal slowing refers to a slowing of brain waves in a specific area, in this case, the left hemisphere. This type of abnormality can be caused by a variety of conditions, such as a stroke, tumor, or infection. Day 4, her temperature stayed around 38 degrees Celsius. She was fully oriented and able to converse and provide details of her life. She had a tremor, which was prominent in her right arm, but the patient, as stated, was coming towards being fully oriented. Day 5 through 7, she had a tremor that affected both arms and legs with use but disappeared at rest. And this is where the patient started to become fully alert and lucid, ate well, no headache, cerebrospinal fluid remained sterile, and she was able to be discharged to go home.
Okay, so analysis of the findings. So presence of Koenig sign indicates that the patient may have meningitis or other conditions that cause inflammation of the meninges. Hematological laboratory tests, they're used to evaluate the conditions of blood forming, which is basically blood cells. And that's very important in this case, especially because we think it's a viral infection, and especially because she had Hodgkin's disease, which is a cancer to the lymphatic system. But basically these results came back normal, with the only deviation being a lower than normal amount of lymphocytes in the blood. Staining of a specimen of cerebrospinal fluid disclosed abundant leukocytes, but no acid-fast bacilli or other macro or microorganisms. And it's very important because these microorganisms are often in the form of bacteria or viruses and cause infection or sickness, some of which are the causative agents of commonly known diseases such as tuberculosis, pneumonia, HIV/AIDS. So not having their presence is good in this case. So there was an MRI study done of her brain, came back with 2 different findings. Showed a subtle hyperintensity in T2 images of both hippocampal regions. And just for context, this is not the patient. It's just an example of what hyperintensity would look like. This signifies the chance of an array of different causes, from inflammation to demyelation, or even the presence of tumor or other lesions. So the other finding was slight meningeal enhancement, and those arrows point to what slight meningeal enhancement would look like. And it signifies the abnormal increase in signal intensity of the meninges. Basically, the characterization of infections, inflammation, tumors, and bleeding of the meninges. There was a signal ranging from isointense to hyperintense within the sulci of both posterior temporal lobes. In essence, chance of high protein content in the cerebral spinal fluid.
The EEG examination displayed, as previously said, generalized low amplitude slowing, showing that the electrical activity in the brain was slower than normal, meaning the slowing was happening more on the left side of the brain, and no signs of abnormal electrical activity that could indicate a seizure or epilepsy were found. PCR testing for the presence of the DNA of a variety of viruses was done and came out negative. Another MRI study revealed high-intensity signal in the back part of the parietal lobe near the outer layer of the brain, a finding that is nonspecific for meningoencephalitis.
Okay, so when a young and healthy individual afflicted with a febrile disease, which is just a disease characterized by fever, comes in, and that disease is accompanied by headache, photophobia, which is sensitivity to light, neck stiffness, which progresses then into somnolence, drowsiness, and disorientation developing over a few days, doctors have to assume or try to test for acute meningoencephalitis as a diagnosis. It just makes sense. Now, in this case in specific, the high protein content in the cerebrospinal fluid, the EEG abnormalities that point to a slow level of electrical activity in the brain, subtle hyperintensity in the meninges and hippocampus are all reasons why acute meningoencephalitis would be a diagnosis. Now, I put meninges and hippocampus. There was also hyperintensity in the back part of the parietal lobe, like we said. That's why it's not meningitis and rather meningoencephalitis. If it had just been the meninges, it'd be meningitis. Also, symptoms, signs, and laboratory findings, such as her fast clinical recovery, show that stroke, brain absence, and brain tumor are highly unlikely. So, I got a smile out of you, awesome. All right, coming up with a completely different diagnosis to acute meningoencephalitis would be not only difficult, but most likely wrong. A true area of contention and diagnosis, rather, comes from deciding the cause of the meningoencephalitis, as nearly 100 types of microbes can cause acute meningoencephalitis. Now, herpes simplex type 1 is the most common form of sporadic encephalitis in the United States, and the symptoms presented by a patient match. But the absence of neurological symptoms or abnormalities in the temporal lobe, predominance of neutrophils on the initial analysis of the cerebrospinal fluid, the patient's rapid clinical recovery, and PCR all serve as reasons to discredit herpes simplex type 1 from being the cause of this acute meningoencephalitis. But none of these findings, however, fully rule out herpes simplex type 1. And on admission, the patient was appropriately treated with acyclovir, which is an antiviral medication. This treatment ceased as soon as the PCR results of the cerebrospinal fluid came back as negative. Okay, so the other likely causative agent for this case of acute meningoencephalitis are arthropod-borne viruses. Now, given the patient's home in Massachusetts and her travels in Missouri, 3 viruses in particular deserve consideration. They are EEE virus, which is Eastern Equine Encephalitis virus, St. Louis encephalitis virus, and West Nile virus. Now this image just shows that arthropod-borne viruses are viruses in which viral replication and transmission cycles are usually between birds and mosquitoes, but in some cases, humans and horses do become incidental hosts, and that's where we get these sicknesses, these diseases. So let's talk about these differential diagnoses. Eastern Equine Encephalitis virus, EE virus, had minimal activity in Massachusetts in 2002. Freshwater swamps and warm marshes in New England are common sites where infections with EEE virus are acquired, and the patient's clinical course is compatible with the diagnosis. But the characteristic leukocytes, hyponatremia, and focal changes in basal ganglia and thalami on MRI imaging were not observed, and those are very characteristic of EEE virus. For St. Louis encephalitis virus, it has not been documented in Massachusetts, but because this patient traveled to Missouri by car, the virus should be considered in the differential diagnosis. Our patient's clinical course is compatible, but the diagnosis is usually associated with a predominance of monocytes in the cerebral spinal fluid, which is something we have not seen in this case. That being said, we can't rule them out fully without actual serological testing. So West Nile virus. Muscle weakness and diminished reflexes are more characteristic of West Nile virus than the other two viruses that we've talked about, as is the increased concentration of leukocytes and protein in the cerebral spinal fluid. Normal cranial CT scans, also very characteristic of West Nile virus, and the mild clinical course with rapid recovery as well. But specific testing is still necessary to confirm the diagnosis. To rule out two of these three possible diagnoses, doctors used plaque reduction neutralization test, which is a laboratory technique used to measure the presence of neutralizing antibodies in a person's blood sample or serum. And the enzyme immunoassay, which is a laboratory technique used to detect and quantify the presence of specific substances, such as proteins and hormones, an example. It does this by utilizing the binding between antibodies and antigen, and to identify and measure target molecules. In this patient, the cerebral spinal fluid was obtained 4 days after the onset of the symptoms, and serum samples drawn from the 5 and 6 days after the onset of the symptoms were available for evaluation. All three specimens were positive for West Nile virus specific antibody on an IgM antibody capture enzyme immunoassay. And I'm gonna give you more of a background on what this is. In essence, they have an assay in which they present a specific antigen-coded surface that is similar to that of West Nile virus. And to prompt endogenic antibodies to bind, they basically just put it in the body. So after this binding has occurred, it is detected by a secondary antibody, which then goes in and then releases a second signal, which could be fluorescent light, or let's say fluorescent light. So if we look at this, we'll see that we see positive for West Nile virus, but negative for the others. If you look at real-time PCR, we see negative, which we would think, oh no, they don't have West Nile virus, but it most likely just means that she has beaten the virus at this point and it's no longer in her system, but the antibodies are still there.
So there's no effective therapy that has yet to be demonstrated, although uncontrolled studies of treatment with interferon alpha and ribavirin are in progress. Over-the-counter painkillers and corticosteroids were used to alleviate symptoms, but as shown in the table, there are prevention techniques used for the West Nile virus infection, which is reducing exposure, use mosquito larvicides or maturation inhibitors, spray insecticides, and use insect repellents. These are all things that will pretty much help your chances of not getting bitten by a mosquito. But if you come along with the West Nile virus, there is no specific treatment that's shown to help. It's usually with time. So yeah, thank you.